person. The talk which I've been assigned is close to my heart because imaging for intratracheal septum for device closure is something which is critical when we talk about various procedures being done for this particular area. I think first and the foremost thing is to understand the anatomy of intratracheal septum. And I think a basic understanding of the anatomy is a prerequisite for any echocardiographer or a cardiologist who proceeds with device closure of PFO or an ASD. I think we need to remember that left atrium is posterior and to the left of right atrium, and intraatrial septum is not a straight structure, it's obliquely oriented. And I think fossa ovalis is something which is central depression within the intraatrial septum. Then we have this limbus of fossa ovalis, which is a muscular structure around fossa ovalis. And we know that embryologically, septum primum is the embryological left-sided layer, and septum secundum is embryological right-sided layer. And if we have to mark the different defects, we can mark them as secundum ASD, primum ASD, and of course sinus venosus ASD, which is close to the insertion of right upper pulmonary vein close to SVC. So I think the modalities which we have in terms of evaluation of intraatrial septum, we all know are transthoracic echo, transesophageal echo, which is particularly relevant in adults. And now I think with the availability of 3D echo, things have improved even further. ICE is also is very limited, and because we are not using it, I'm not aware if any center in the country is using it, but of course it has cost implications. Hence, I will not be really going through ICE in detail. So when we go for echocardiographic assessment of an intraatrial septum, of course, it helps us in various ways. First and foremost is patient selection for any device procedure, real-time procedure guidance, which is crucial, assessment of device efficiency, and of course, complications, and then a long-term follow-up is again dependent upon echocardiography. Now, the two major procedures that we carry out in terms of intraatrial septum are PFO and secundum atrial septal defect. Of course, we are closing the sinus venosus defect as well, but that's not really dependent upon intraatrial septal anatomy. That is totally different context. So I will be only targeting PFO and secundum ASD. We all know that PFO is a tunnel between septum primum and secundum, but secundum ASD is a true intraatrial deficiency. And obviously these sizes vary. PFO can be up to 10 millimeters as well, but it's usually 1 to 5. And secundum ASDs can be as large as 4 centimeter or above. And shunt, historically or classically, in PFO would be right to left with increase in right atrial pressure. But unless there is Eisenmenger, secundum ASD will be left to right. And hemodynamics, of course, you will not have any RV volume overload with PFO, but significant RV volume overload with an atrial septal defect. And detection, of course, that is facilitated by color Doppler in ASD and by bubble study in PFO. And of course, the indication is paradoxical embolism and RV volume overload. I will take you through PFO first. I think patient presented, this particular patient presented with stroke. You can see a small atrial septal defect. When you are going to measure it for potential closure, then you have to measure it from thick part of the septum from one side to the other. And that will be taken as the potential size when we are talking about the device in terms of device selection. For detection of PFO, I think assessment is crucial. And two important contexts are Valsalva maneuver and what we call agitated saline bubble study. And I'm showing both on the right of the screen. You can see Valsalva maneuver showing right to left shunt over here. And this is a classical bubble study. You can see bubbles going onto the left side as well. And I think we can decide the grading as well by seeing what sort of bubbles or number of bubbles go to the other side as being small, moderate, or large. And I'm sure each one of the person who does echocardiography knows that Valsalva is crucial because you will be missing 50% of PFOs if we do not do a Valsalva maneuver while we are doing a transesophageal echocardiogram. this tunnel can be sometimes misleading, and one can argue whether this is a true atrial septal defect or a PFO. But I've deliberately brought this particular patient because it was sort of nominated as an atrial septal defect. You can see how the septum is moving. We measured it on the echo, and you can see the areas of measurement 3.8 and 8 over here. But if you take the whole lot, then it can be up to 16. But we thought that we will do a balloon here. So we do a balloon stretch. And when we stretched it with the balloon, it went up to 10.7 millimeters. So we decided to take an 18 millimeter device and close this particular defect with an atrial septal defect. You can see, and unfortunately, this device embolized. And I think one of the reasons why this embolized was because this was a tunnel-like PFO, and the important message here would be you err on the side of caution, and when you are talking about PFO, go for a bigger device rather than for a smaller device, because you can make mistakes in these patients. Sometimes you are confronted with this atrial septal aneurysm, where particularly in bicable view, you will see that the excursion of septal tissue is more than 10 millimeter from the plane. And that's where I think we need to be very careful in terms of sizing it, because then you really need to size it from here to make sure that you select an appropriate size PFO device for closure of these patients. Coming to atrial septal defect, which obviously is a far more common procedure that we do in clinical practice, and I'm sure I don't need to go through this whole context here, but the only defect which we close with a device is what we call secundum ASD, although the primum or coronary sinus or sinus venosus defects are also there, but they are all closed surgically, although SVC type is now being done with a covered stent as well. So what is the data required by echocardiographer when we are closing an atrial septal defect? Type of ASD, most importantly, exclusion of any pulmonary venous abnormality, because you may have an anomalous pulmonary venous drainage. You must make sure that you look at mitral valve, you need to look at ventricular function, and you will be surprised how many of these patients, particularly adults, would have some degree of left ventricular dysfunction, and that totally changes your planning. Of course, the pulmonary artery pressure, any thrombus or clot in the presence of arrhythmias, and then, of course, measurements. And I think measurements would only start once we have evaluated the interatrial septum for all these parameters which I have mentioned. And of course, then you will go for number of ASDs, size of ASD, total septal length, and rims. So 4 fundamental things that we look for: rims, total septal length, size of ASD, number of ASDs. Total septal length may not be very relevant in adults, but is very relevant in pediatric age group. Transthoracic echo, I think you can make mistakes here, and I'm sure everyone knows about those potential mistakes, because you would be looking at parasternal, apical, and sub-xiphoid, and I think we must be able to demonstrate an ASD in sub-xiphoid position, or what we call subcostal. And if in any doubt, please go ahead in an adult with a transesophageal echocardiogram, particularly if you're not able to find significant RV volume overload. So on transthoracic echo, I think it's easier on transthoracic echo because you are able to see the atrial septal defect very clearly, as you can see. But you can also see that the superior margin over here is totally absent in this particular patient. Although we will see this from all the angles, but absence of superior angle will make this patient particularly not suitable for device closure. If we go ahead with the subcostal window, you can see over here absence of IVC margin over here. It's a large septal defect. You can rotate around in the subcostal window and make sure that you look at all the margins of interatrial septum to make sure that we are not missing any of these margins. Of course, both on color and 2D. Coronary sinus ASD can be a little difficult to pick up, but I think it needs to be differentiated from an atrial septal defect of secundum type. So we need to make sure that we are not actually dealing with a patient with coronary sinus ASD as is seen in this particular patient. And that will be true for sinus venosus ASD as well, because these patients are not the ones that you will consider for device closure. Now let's come to the transesophageal echo, because that's really what is required in these patients. As you would see on your right in this running movie, that I'm going from 0 all the way to 180 degrees. Although we divide them into uh, short axis, long axis, bicable views, but I think any good echocardiographer will go through the whole lot, because you need to make sure that you are seeing these margins in all positions, and I will be going through that in a moment, because it may not be a circular defect, it may be an oval defect, and it's logical that any defect which is oval or circular would not have any fixed number of rims. So the entire rim starting from 0 to 180 is important. Now, this landmark paper from Behind the Mean, which talks about the superior margin, inferior margin or the IVC margin, posterior margin or the free wall margin, aortic margin, and then of course the IVC rim and SVC rim. And you can see how these are shown over here. In four-chamber view, you are seeing AV valve and superior margin. In short axis, you are seeing aortic and posterior margin. And in bicable view, you are seeing an SVC and IVC margin. So you can look at these margins in these views particularly, but you really need to go through the whole 180 degrees to make sure that all the margins are adequate. So what is an adequate margin? I think for a device closure of an atrial septal defect, generally speaking, you would need a minimum of 5 millimeters. Although for a superior rim, we would even think about 6 to 7 being a borderline. Because length is not the only issue that you look for. You need to make sure that it's thick enough that it will hold the device. If it's very thin or floppy, then even 5 or 10 millimeter may not be adequate, and you might be looking for a significantly higher context. As you can see over here, superior rim, AV valve rim, aortic rim, which is deficient here. This is posterior rim, SVC rim, and IVC rim. So you need to make sure that all these rims, other than the aortic rim, because you do not need that 5 millimeters for an aortic rim. You can get away with that. Then, of course, is the sizing of the ASD. You need to size these patients, which is at least in two perpendicular planes. Please do not rely on one measurement. You need to see the ASD in all four, at least in all four views, to make sure that you're getting the correct size of an atrial septal defect. Many of these are oval defects, and you might underestimate, and that may lead to, of course, embolization of the device. So minimum four-chamber view and bicable view, although it is recommended that you look at it in all views. Total septal length is only important for pediatric age group, because for adults, we generally assume
1.5 minutes
that
remaining.
the patient is being put in for an atrial septal defect closure, they are suitable. So for pediatric age group, your AV valve rim plus average size of the ASD plus superior rim. Please do not measure it from here to here. You can underestimate it. You need to measure them separately. So you need to measure the AV valve rim, you need to measure the superior rim separately, and get the average of an atrial septal defect which you have measured in different views. Second important thing is to make sure that you are dealing with one ASD or two ASDs. As you can see over here on the right of the screen, here you have two ASDs with an intervening tissue. Your approach to that patient will obviously change. You might need two ASD devices, or you might stretch it and make sure that you are dealing with one ASD, or you cover the other ASD with a relatively larger device. So there are various ways that you will deal with that, but you need to tell the operator that there are two ASDs and not just one ASD. Now, one thing which is important for echocardiographer is, of course, to find whether the rims are adequate or deficient. You can see over here, your posterior rim is deficient here. Superior rim is deficient here. Aortic rim is deficient here. And there is no IVC rim here. IVC rim is deficient here. So all these four rims are crucial, but the most important is IVC rim. because IVC rim will tell you whether, sorry, it's
Sir, sir, a very
now,
fascinating talk as always. I think our system automatically cuts it off after 15 minutes.
sorry.
So really apologize about that.